Good afternoon and welcome to March's Health Policy Grand Rounds with the Institute for Health Policy Studies at UCSF. Today, we are really happy to have some of our own UCSF colleagues do the presentation for today. We have Julia Adler-Milstein, who is a professor of medicine and is director of the Center for Clinical Informatics and Improvement Research, or CLIIR, and she is also core faculty at the Institute for Health Policy Studies. She's a leading researcher in health IT policy with a specific focus on electronic health records and interoperability. She's examined policies and organizational strategies that enable effective use of EHRs, electronic health records, and promote interoperability. And she's an expert in electronic health record audit log data and its application to studying clinician behavior. She is accompanied by other colleagues at CLIIR. AJ Holmgren is an assistant professor of medicine in the Department of Medicine and also at CLIIR, and he's affiliated faculty at IHPS. He's an expert on the use of information technology in healthcare delivery. Dr. Holmgren's research focuses on the impact of information technology on patients, clinicians, and healthcare organizations, and seeks to identify strategies to improve the quality and experience of care using digital tools. And then finally, we have Ben Rosner, who is an associate professor of medicine and an informaticist and digital health researcher at CLIIR. He also is affiliated with IHPS, and he serves as a digital health medical advisor to several national digital health not-for-profit organizations and continues to work in policy related to digital health. His research at UCSF involves evaluation of digital health tools, understanding user behavior through audit logs of the electronic health records, and using digital health tools to improve patient engagement and the pillars of the quadruple aim. So we are really fortunate to have our own colleagues here today, and I'm going to hand it off to Julia, who I believe is going to be the MC and leader of the session. I will note that the chat is open today for conversation, questions, and discussion, and also the Q&A is open, but we encourage you to use the chat, but we'll be kind of keeping an eye on both of those venues for communication and sharing. So take it away, Julia.
Wonderful. Well, thank you for that introduction. We're really thrilled to be here today. While I think we know many of you, we haven't had the opportunity to present our research and to do so in the context of our center, where we're doing a lot of different types of research projects. And so we wanted today to try to give you a potpourri so you get a sense of all the different types of projects that are happening within CLIIR. So I'm going to give you a little bit of an overview of CLIIR and then present our first project and then hand it off to AJ and then to Ben, who will give you a couple of additional examples of our research. I'm not sure that we're going to have a huge amount of time for Q&A, as Joanne said at the end, so please do use the chat actively if you have questions along the way, and we'll try to answer them as best we can. So CLIIR, our Center for Clinical Informatics and Improvement Research, we're a collaborative research center. And our focus is really on how do we take this huge investment in digital capabilities that our health system has made over the past decade and turn that into better health system performance. And so we really try to think about innovative ways to do that. As you'll see, I think from our projects, we really do try to touch a lot of different types of dimensions of digital health impact. So that we can understand across the quadruple aim all the different opportunities for improved digital performance. We do some of our work very locally. Again, some of our projects are just at UCSF Health, and a lot of them are much broader than that, drawing on national data sources. And we really want to, again, be answering questions that are relevant both at the policy level as well as those that are relevant to sort of the day-to-day experience of patients and clinicians as they are using new digital tools in ways that drive the quality and the cost of care. So today, as we exist, we have 3 faculty, a postdoc, a data science team, and a set of sort of research staff who work together very collaboratively across our portfolio of projects. And each year we've grown, I think, in my opinion, quite dramatically. And in 2021, we had more than 25 publications across our team, 8 new grants that were over 2.5 million in research funding. So it's been really fun to see the growth of CLIIR as we've added just a terrific team of folks. So, as I said, CLIIR, generally is really focused on studying this question of how do we take digital tools and turn them into better health system performance. But one of the really foundational pieces that allows our work to be unique is drawing on a source of data that many people don't even know exists. I think many of you think about EHR data and would equate that with clinical data, right? Data about the patient's records, right? What medications are they taking? Were they readmitted? And so all of that data, of course, is in the EHR and is hugely valuable. But there's a second type of data that lives within the EHR that is, instead of patient-centric, is user-centric, right? So what are our frontline clinicians, administrators, truly anyone that touches the EHR? We are logging what they are doing at every second of every day in the EHR. So it captures who is doing what and when. And that's a really tremendously powerful source of insight. If the kinds of questions you're interested in are, how is healthcare being delivered? How are clinicians spending their time? What information might be relevant to a given decision? How are our different care teams communicating with each other? So it takes the complementary focus on sort of what's happening with the patient and almost brings in the context of like, well, how might that decision have gotten made, or what happened prior to a patient being discharged? So for health services researchers and health policy researchers, I really think these data are a gold mine that have been untapped largely in the context of research. So our center has spent a lot of time investing in understanding these data and how to use them, and then thinking about what types of projects we can apply them to that really offer a novel window into clinical decision-making and healthcare delivery processes in order to better understand outcomes. So again, just to be a little bit more specific about these data, because they are so foundational to what we do at CLIIR, they're often called audit log or event log data. And so, they are tied to the patient because what's happening in the EHR is about our patients. But it really takes a set of actions that, any number of different, EHR users could do, and says, okay, who accessed the patient record? Which patient record were they accessing? When did that access happen? And what type of action was being taken? So that could be a record review activity, that could be entering an order, that could be some type of clinical documentation, or any number of other types of actions. So you can then take these event log data and turn them into a wide variety of types of measures. You can simply just count the actions that a given user is engaged in. You can start sort of clumping them together in different ways. Probably seems clear that for operations researchers, this is sort of bread and butter. But if you are interested even in just questions about like, okay, well, how much time did, a clinician spend writing a clinical note, for example, or how often, after a social worker wrote a social work note, how often was it read and by whom? These are the kinds of sort of identification of activities that's possible with these data. You can do all sorts of things with activity sequences and sort of phenotyping of user behavior. And you can then take those and really think about teams and teamwork and measure in a very granular and specific way, like who are all the users that touched a given patient chart and how do those then form networks of providers who are caring for the same patient. So we're using also sort of team-based network measures to look at the performance of healthcare teams using these data. So a lot of different opportunities for different types of measures that can be relevant, again, to sort of health services research and health policy questions. So across CLIIR, we do use these event and audit log data as a foundation. And what sits on that foundation is work in 3 particular areas. We do a lot of work on interoperability, trying to understand how data can better flow across the healthcare system. And from a patient's perspective, how can that patient's chart follow them no matter where they receive care? We're also doing a lot of work around clinician and care team work and well-being. This issue of burnout, I think, is very familiar, and these data that I described are very useful to trying to understand the sort of nature of frontline work and what might be contributing to burnout from an EHR perspective. And then last but not least, we're really thinking about the patient engagement piece. I didn't explicitly mention this, but the audit log data also capture what our patients are doing through the portal and sort of all the different sort of digital touch points they have with the health system. And so we can also do a lot around measuring patient engagement and what patients are doing. So a lot of exciting opportunity there. So we're just going to walk you through projects in each of these areas to give you a more detailed sense of the types of projects that we do, but really do encourage you to reach out if there's one or more of these areas that you're interested in hearing more about, because we have a lot of different project work within each of them. So I'm going to talk about the interoperability project before I hand it off. And what I really like about the project that I'm going to tell you about is that it has really big policy implications, but is a study that we were able to do just using UCSF health data because the opportunity for insight exists just sort of in the four walls of our own institution. So interoperability is a major policy priority. It just continues to be a space where there's active policy making. And the investment to date has gotten us to a point where the majority of US hospitals are able to exchange patient records electronically. But as we've sort of studied the maturation in this space, what we've learned is that almost a little bit more than a third of those hospitals, while they're able to exchange data electronically, report that they're rarely or never actually using that data as part of frontline care. And when asked why, they said, well, while we can get that information electronically, it's not really integrated into our local health record. And so it's like you could find a separate document or a PDF maybe with that information, but it's not that user-friendly if I keep having to go to somewhere else in our EHR to look at it. And so this barrier of difficult to integrate that information from outside sources into your local or home EHR is cited as a major barrier by more than half of hospitals. And so this question of like, well, wow, that's really interesting that we've built all this connectivity, but we haven't sort of done that final piece of really integrating that outside information in a way that makes it easy for clinicians to use and to really understand that full picture of what's gone on with that patient. So Epic, which is a very large vendor nationally and is also the vendor that we use at UCSF, recognized this problem and sort of over time has improved their EHR user interface design to do a better job of integrating these outside records sort of into the home system. And a couple years ago, just as part of a standard upgrade, frankly, I don't think anyone was even really paying attention to it. But one of the features that they changed was instead of having these outside records sit in like a separate part of the EHR where clinicians would go to see them, they started actually pulling in and integrating those outside records with our local UCSF health data. And so you could see, for example, here on the chart review tab, a list of encounters, a subset of which had taken place outside of UCSF, and then the others were kind of our local list of encounters. So for the first time, if a clinician went to the chart review tab and just said, oh, I want to see what encounters these patients have had, all of a sudden there's this much more complete and longer list of encounters. And if you moused over the encounter from an outside organization, you could actually pull up and see the summary of what happened in that outside visit. So again, truly from one day to the next, these data weren't integrated onto chart review. We turned on this upgrade. The next day they were integrated. And so we looked at that and said, wow, that's really solving this pain point that we know at a national level is preventing clinicians from regularly using outside data, even when it's sort of theoretically available in the EHR. And so let's study whether this user interface design change had an effect or not. And so what we did was basically just count how often are frontline clinicians at UCSF looking at an outside record that's in the EHR. Again, these have always been available within the EHR. The only thing that changed was where in the EHR they were made visible. And they were basically just moved to kind of a more obvious place that was where we would also see our UCSF health encounters. So I don't think you need an advanced statistics degree to see whether or not this had an impact. So this was in, I think, July of 2018 or 2019. I've lost track of the years, but pre-COVID, this user interface design change went into effect. And you can see that almost overnight, there was a dramatic increase in the level of outside record viewing. The interrupted time series model is that this was equivalent to a one-time level change of about 30,000 outside record reviews per week. And again, this is just UCSF health data. So all we did was just change this user interface design in a fairly subtle way, had a huge increase on user behavior. Now, people have looked at this and I think appropriately been skeptical, like, well, what else might have happened at that point in time? It turns out this was July. This is, when we have new interns, like maybe just we had a set of new interns that were like really interested in, outside record data. And so this is where I think the audit log data is so cool because we can actually see, well, what screen were they on when they viewed the outside record data? Were they on the new screen, this encounter list within chart review, or were they kind of on the old screen, which was all of the outside record data that existed outside of UCSF, but that was kind of kept separate from our own data? And so the gray line shows you how previously they could access these outside records. It's called the Care Everywhere tab. And what you could see is there was really no degradation. That continued to be used even after this user interface design change occurred. And then you can see the black line, which is sort of the new pathway, which is were they on the chart review screen when they looked at this outside record. And that's where you can see that this huge bump occurred. And so again, we can see that this is largely sort of a net new set of viewers who before either didn't know or didn't take the time to go to that other place in the EHR that had all of these outside records. But now that you put them in a more obvious place and integrated them perhaps in a more intuitive way, they were taking the time to look at these outside records. So again, there's a lot more to talk about with this project, but we just wanted to give you a flavor of the work. This is now moving on because we have said, based on the success of this outside record integration, we're now going to move on to integrating lab results, which I think coming out of COVID is perhaps even more obvious why it's important. How do we have a single set of lab results that you can look at for a patient rather than looking at the UCSF only lab results and then looking separately at any lab results that may have been done outside of UCSF? So we're excited to go on and study the lab result integration piece. And then ultimately, I think we'll have more of an opportunity to tie that to outcomes. And we can look at things like, were labs less likely to be duplicated or repeated, for example, after this user interface design change to integrate labs when live. So that's our first project that we wanted to tell you about. Again, an example of using audit log data to look at a question around a user interface design change that relates to this broader question of how do we approach interoperability in a way that actually is likely to improve patient care by making sure that data is not just available in concept, but is actually looked at by frontline clinicians as part of clinical decision-making. So with that, I'm going to turn it over to AJ for our next section. And if there are any questions, please do put them in the chat.
Thanks, Julia, and thanks, Joanne, for the introduction earlier. Advance the next slide, please. So I'm going to talk about our next pillar at CLIIR, which is the questions surrounding physician and other clinicians' work in the EHR. I think it's probably pretty unsurprising to many of you in the audience that there's been a big sort of unintended consequence of digitizing our healthcare system, and that has been a big amount of burden on clinicians. In essence, EHRs make it really easy to take work home and do work after hours compared to charting on paper. The systems are perhaps not the highlight of usability. Often EHRs look more like a Windows 95 application than the latest 21st century smartphone app. And the whole system often is sort of the burden of many clinicians. You'll see many articles in the popular press emphasizing why doctors hate their computers. So in this study, we wanted to use national data from the largest Epic vendor to look at what was the impact of the COVID-19 pandemic on clinician work, given how much is going around about how much clinician EHR use leads to burnout, especially since we saw a dramatic change in the way we deliver care during COVID. We wanted to look at how this is impacting their use of technology. There's a whole lot of different things happening during the COVID pandemic, especially at the onset. We're seeing a big increase in virtual care, which may increase EHR use. But at the same time, in ambulatory care, we're seeing a big drop in volume, which may lead to a decrease in daily use. So we wanted to take a look at this and sort of answer these questions using big national data of what's going on with clinician EHR use. So the next slide, please. This is national data from Epic Systems ambulatory care EHR. So this is all physicians as well as advanced practice practitioners, including NPs or PAs, anyone with scheduled appointments in the EHR. This comes from 366 health systems from December 2019 through January of 2020. And the data is expressed at the weekly level. And then these are aggregated up to the health system level. So what we have is each health system provides a week of data, and that for that, we'll have their average EHR time across their clinicians. The next slide, please. Here's sort of our top line results, which I think make a lot of sense here. On the left, we have total EHR time per day expressed in minutes. And on the right, we have after hours time per day. The black line is the value of EHR time. The dotted green line is daily encounter volume, just to give a sense of what the volume of ambulatory care is in each individual institution, as well as the national COVID case count to give a sense of what the pandemic looked like during that time. The black bar and the vertical line there is the California shelter-in-place announcement, which was the first shelter-in-place announcement in the nation. And we sort of use that as our proxy for the beginning of the pandemic. So you can see, unsurprisingly, at the very beginning of the pandemic, there is a massive decrease in ambulatory volume as a lot of appointments are simply canceled, and a corresponding decrease in EHR time. However, once you reach about July, we see that ambulatory volume has nearly rebounded to its pre-COVID level, and EHR time is a little bit above where it was. So we're seeing a little fewer patients, but we have a little bit more EHR time. It's not a huge effect, but it's certainly there. A similar story happens with after hours time per day. This is time outside of scheduled clinic hours where physicians are working actively in the EHR, where even though ambulatory volume is a little bit down compared to pre-COVID, after hours time is slightly elevated. You can go to the next slide, please. These are simply event studies that look at, include organization level fixed effects as well to estimate our baseline week of 2 weeks prior to the California shelter in place, including controls for average daily volume as well as organization fixed effects, what's happening with EHR time per day. And we can see by July of 2020, for the most part, we're seeing a little bit increase in EHR time per day. So physicians are spending more time working in the EHR, and unsurprisingly, that's spilling over into their after hours time. While it's not a huge effect, it's about 5 minutes of extra EHR time per day, it adds up over the days to become a good amount of time after when you sort of calculate these on a weekly or monthly level. On the next slide. The next thing we wanted to do is, given that we see that clinicians are spending more time in the EHR, where is that time coming from? So we break down EHR use into sort of 4 broad categories. Time in basket, which is messaging with patients, with other members of the care team, or reviewing results messages, clinical review, orders, placing orders, retracting orders, et cetera, and then documentation in notes. And looking over time here, we can see, unsurprisingly, at the very beginning of the pandemic, there was a massive spike in in-basket volume. A lot of this were things like prescription refill requests from patients who had no idea when the next time they were going to be able to see their physician in person would be. So they're ordering a whole bunch of things that they might need to weather out the pandemic. This falls down, but then goes right back up in terms of physician time per day and stays elevated significantly above where it was in the pre-pandemic period. Similarly, time in clinical review stays a little bit above where it was in pre-COVID, while orders and notes are closer to where they are. So what we see here throughout the entire, all of these data is that there is a huge disruption in the delivery of ambulatory care and EHR use from March of 2020 through July. By the time we get to July, we're seeing a consistent story where EHR use is up, driven almost entirely by time managing their inbox, as well as reviewing patient information in clinical review. On the next slide, please. So given that this increase in inbox time seems to be driving a significant amount of this additional EHR work, we wanted to see, looking at the volume of messages, where are these messages coming from? So in the upper left corner there are messages from patients or patient medical advice requests in the Epic parlance. And these are all sort of set to their pre-COVID baseline for each organization. You can see patient messages are up about 150% compared to the pre-COVID baseline across the national data set, which is a huge amount. So that explains a pretty significant chunk of why physicians are spending more time in the EHR and in their inbox, is that they're simply getting more patient medical advice requests. I'm not sure exactly what about COVID it was that sort of clued patients in that this was an available way to receive care and communicate with their physician, as patient portal uptake and use of these messages was relatively low in the pre-COVID period. It may have just been the activation energy necessary to set up for a MyChart account, or if you were ever using telehealth, you had to have a MyChart account. But regardless, we've seen a sustained increase in messages from patients to their clinicians, whereas other messages have sort of returned to their pre-COVID baseline. Messages from other members of the team were slightly elevated, likely reflecting an increase in telehealth, as when team members are no longer co-located, they need to communicate through other methods rather than simply speaking to each other in person. Whereas prescription messages there on the bottom left is also returns to its pre-COVID period pretty quickly. Results messages also return to their pre-COVID baseline level quite quickly. So really this is driven by additional demand for clinician time from patients. And on the next slide, please. What we wanted to do was look at not all of these messages take the same amount of time to respond to and to look at. So using a two-way fixed effects model, we wanted to say, okay, what is the impact of each marginal message on physician time in the EHR? And the big result here is, unsurprisingly, messages from patients take a significant amount of clinician time, almost 2.5 minutes per message in terms of the time they spend in the EHR per day. Given that we're seeing such a big increase from the baseline level of 150% more patient messages, this is obviously putting a significant amount of burden on physicians to spend time doing what is previously often uncompensated care. Now, the public health emergency of the COVID declaration does allow physicians to bill for these encounters, given some specific rules around how much time they spend, but this is generally not being used too much. On the next slide, please. I think this has some pretty important policy and practice takeaways, which is that big disruptions in EHR work came at the onset of the pandemic, driven by sort of these two opposite forces of telehealth and a big reduction in volume. But once we get to about a steady state in July of 2020, where in-person ambulatory care has mostly reopened, but with a much larger proportion of virtual care, we're seeing an increase in EHR time per day that's spilling over into physicians' home life outside of clinical hours. And most of this is driven by inbox management and responding to patient messages with a little bit in additional clinical review. And there's a really big increase in patient messages, which demand the most clinician time. The next slide, please. And then just sort of to give you a sense of what other projects we're doing that are policy relevant evaluations with this sort of big national EHR metadata, things like evaluating the E&M coding changes that took place in 2021, or the impact of new patient access to clinical notes on physician work are really important. We want to see what the impact of policy changes are on physician work, and this sort of really detailed EHR metadata is a really fantastic way to do that. We can also look at more granularly what the impact of telehealth is on demands of physician time and how their decision-making has changed when delivering care virtually. And finally, we're working hard on finding effective strategies to reduce documentation burden, such as identifying the optimal use of EHR tools, like how much copy and paste or templated text leads to increased efficiency versus decreased efficiency. And also evaluating the use of documentation support staff to increase health system capacity. So for providers who are otherwise supply constrained, are hiring scribes allowing them to increase access and see more patients? These are the sorts of questions that this sort of big EHR metadata is great for. And I also want to put in a plug for, if you have any interesting questions that national Epic EHR metadata might be able to answer, please reach out to the CLIIR team, as we think this is a fantastic data resource. And with that, I'm going to turn it over to Ben to talk about his project.
Thanks, AJ. Thank you, Joanne and Beth. I'm going to talk about another project that's in the second pillar that AJ was talking about, clinician and care team work and well-being, before I turn to our third pillar, which is about the digitally enabled patient. So one activity that we have been using the audit logs for is to understand trainee behavior, specifically residents, and how they grow over time during the course of their training in terms of using the EHR. Next slide, please. And if you can go to the next slide as well. So the motivation for this work actually has come from several areas. One is at the institutional level. UCSF's Innovation Fund for Education was looking for tools that could help assess competency-based learning and reporting on performance. And also they're looking for novel approaches for learner assessment. Next slide. Learners themselves are interested in skills, learning EHR skills that are going to be translatable beyond just their training. Next slide, please. Teaching faculty also, are looking for objective information they can use that may supplement their assessments of trainees who are performing clinical work on the wards in the hospital. Next slide. And at a broad level, in graduate medical education, there have been calls for leveraging big data in the EHR to help guide training and also assessment. So these several sources of motivation sort of merged into what a project we call the Trainee Digital Growth Chart. Next slide, please. So when we think about how trainees learn to develop clinical reasoning skills, the foundational skill is really one about information gathering. Now, that gives a pretty nice and unique opportunity using the EHR audit logs, because we can actually track where are trainees clicking as they're gathering information about their patients. We decided to take a look at the inpatient setting for trainees, residents in hospital medicine, to look at what are they clicking on. For example, when they admit a patient, do they look at the labs? Do they look at the vitals? Do they look at notes that have been placed by the emergency room physician or consult notes? And what perhaps ought they to be clicking on? Are there perhaps some benchmarks that well-seasoned clinician educators might expect of them to do at different stages over the course of their training? Next slide, please. So we actually held a bunch of focus groups with clinician educators, and then we actually, with our data analysts, wrote queries against the CLIIR-ly database to look at where were trainees clicking as they were gathering information at two important activities. One is at the time of admitting a patient, and the other activity category is just during the course of daily activities in the inpatient setting. And then we served these data up in Tableau so that you can see over the course of time. The x-axis basically breaks down a 3-year training period into half-year chunks. And you can see, in this case, an individual. We've used Robert Tombley's name to hide the innocent or the guilty. But you can see how this trainee grew over the course of training relative to a matched cohort, which is the blue band, and how the whole cohort performs against this, what I would call version 1 of a gold standard of expectations that were created by focus groups that were convened by attending physicians. And so both the trainee and the clinician educator, can go into this tool and learn how they're progressing over time and see certain strengths and weaknesses. Next slide, please. The trainees can then also drill into specific areas to see where their strengths and weaknesses are. So this tool has been built and involved a lot of collaboration at UCSF, at the Office of GME, the Office of Technology Enhanced Education. There's actually been quite a bit of interest from other groups. This was actually built for internal medicine and pediatrics, but you can imagine this scaling to trainees of any discipline that's touching the EHR and beyond even UCSF. Next slide, please. So the other things that are really kind of interesting here is that this can also provide some unique insights for the trainee, him or herself, and the clinician educator. This just illustrates one example where a trainee who transitioned from first year to second year, and in the second year in the residency in internal medicine, they go on to sort of a supervisory role of interns. And this particular trainee, you can see, sort of struggled in terms of expected information gathering relative to a benchmark and also to his or her cohort. And this provides an opportunity for clinician educators and trainees to realize where there may be opportunities for improvement. Next slide, please. So from a policy perspective, there have been calls from the Accreditation Council for Graduate Medical Education, NASEM, and others for mechanisms that are really low burden and automated to help sort of drive the next generation of assessment. And to our knowledge, this is one of the first instances of really leveraging the EHR audit log in a purely automated manner to help understand how trainees are growing over time and to aid in the assessment of trainee performance. This has actually resulted in invitation to a summit where there will be researchers and policymakers talking about this very thing, while I will share some of these kinds of findings as well. Next slide, please. And I see a question about, have we considered doing this work with community physicians, assessing variation across seasons physicians? It is, I think, a huge opportunity for future state, because we've applied this to trainees, but frankly, this could be applied equally well to seasoned physicians. And there is an abstract we submitted to the AMIA annual conference, which actually talks about the huge variation, even among seasoned physicians, in what types of things they expect to be examined in terms of information gathering. And that variation is somewhat surprising, but it's interesting because many physicians learn to use the EHR really organically on the fly, essentially building the plane while they were flying it. And so I think there are opportunities to do that. Next slide, please. So our third pillar is on the digitally enabled patient and patient engagement. I spend a lot of my time thinking about patient-generated health data and its use and adoption. And those who are clinicians in the group know that PGHD, which basically are data that are created and reported by patients or family members outside of a clinical encounter to help with a health problem, they have not really gained widespread clinical adoption. But the COVID pandemic created an interesting opportunity to explore their potential use, much in the same way that telemedicine got a huge boost during the pandemic. One of the questions we had was, when physicians are doing telemedicine visits and they don't typically have access to the same things, same kind of like vital signs that are collected in person, might they be more interested in perhaps adopting PGHD as surrogates for the in-person collected vital signs? Next slide, please. So what we did was we used a large national PGHD platform. We got data from the LIG to do an interrupted time series analysis of physician enrollment in, as well as patient-initiated vital sign transmission of non-COVID associated PGHD. These were vital sign like PGHD. This was from 11 health systems, over 4,500 physicians, and 51,000 patients. Next slide, please. And what we see were that the x-axis is time, and that vertical dotted line is essentially early March of 2020, when shelter in place started, is that there were changes in the rate of new provider enrollment in a PGHD platform that was significant. There was a significant change in the slope. So we saw increasing provider receptivity to consuming and receiving PGHD. And what's interesting on the right side, this is sort of the patient transmission of PGHD. Although the change was not statistically significant, you remember from AJ's slide that encounter rates dropped quite precipitously. early on in the pandemic. And so even though there was a precipitous drop in encounter rates, even when you account for an increase in telemedicine, the pace of API call volume or the transmission of PGHD continued. And so in essence, it outpaced the rate of encounters. So this suggested that there was not only new and increasing appetite among providers to incorporate PGHD, but also patients continued to be very interested in transmitting it. Next slide, please. So what are some of the policy implications around PGHD? Well, many of you may remember in stage 3 of meaningful use for EHR use, PGHD were actually included as part of a criterion in stage 3 meaningful use, but was later withdrawn because in part, clinicians were concerned about accuracy and reliability of PGHD. They were concerned about their own liability for PGHD that may have come in after hours, on weekends, et cetera. And in addition, the reimbursement for PGHD, although there are some mechanisms, it's not exactly easy. It remains a little bit challenging. So there are a couple of things that are policy related to PGHD. First of all, as part of CMS's quality payment program and merit-based incentive payment program, I lead authored an improvement activity called Engage Patients and Families to Guide Improvement in the Systems of Care that really was to create incentives for closed loop feedback for applications that involved patients and families and where they could provide information back to providers. In addition, this is quite recent, the White House Office of the Science and Technology Policy put out an RFI on strengthening community health through technology, and they were interested in what technologies during the pandemic were important. And so I submitted a letter describing some of the results around PGHD and encouraging additional mechanisms to make PGHD reporting less burdensome and to honor reimbursement that clinicians spend looking at PGHD. Next slide. And then last, this is also quite recent, just the other week, the Access to Prescription Digital Therapeutics Act was just proposed. This will actually create broader opportunities for reimbursement for prescription digital therapeutics. Some of these may include PGHD, but this really could become a game changer for digital therapeutics in general, and we will see where this bill goes. So with that, I'm going to wrap up my portion of the talk. And I know there are some questions that have come in. I will take a look at answering those, but I wonder maybe if Julia and AJ want to come back on, and we're happy to entertain other questions.
Great. Well, I did not think we were going to get through all of that content in less than an hour, but we managed to. So we do have some time for Q&A. So I think we've been trying to respond to some of the questions in the chat, but if anyone would like to kind of follow up on any of them or or ask a question that they didn't want to put in the chat, feel free. So I can just quickly, maybe there's a couple of threads here about, tying our data to other sources of data like patient satisfaction data, physician, well-being and burnout data and outcomes. I think there's, in general, we've had luck within groups like primary care that do their own survey that's identified. We actually have a set of papers that have come out of using that survey data. It's called the STEP survey in the chat. And so we've had a lot of luck kind of connecting our EHR use data to those types of surveys. What's been harder is at the UCSF health level, if they control the data, so the patient satisfaction data lives there, the sort of enterprise level burnout data lives at UCSF health level, and there hasn't been, I think, as much openness to connecting that data to our work. And then obviously scaling to the national data, thinking about like AJ's data, then it's very, very hard to kind of get a data set that you could connect at the national level. So we've had some luck at UCSF, and I think hopefully we'll be able to do more.
I see Catherine has posted a question around using MyChart to pull in data from outside individual providers and direct to consumer lab tests. which is actually really fascinating. I think that's sort of a twofold question. I'm not specifically aware of my chart pulling in some of those data, but I think the direct to consumer test data showing up in the EHR in and of itself is a very interesting research topic, because I think it begs the question of, how will clinicians react to DTC tests, given that there's quite a variety out there, and how do you know, in a manner that's sort of similar to PGHD, how do you know the accuracy and the reliability of those tests? Can you trust them to make or inform clinical decisions? So it's a question that is both a technical one, and I think maybe like a one that involves physician opinions about these tests, about which many of them don't know a whole lot of information.
And maybe just as a contextual comment on that too, that, right now, we're able to pull in a lot of data from other Epic sites. And increasingly, we're able to get data from sort of other large EHR vendors. But, like our connectivity to kind of, small clinics or, rural health centers, that's where, unfortunately, interoperability capabilities aren't as good right now. So again, what you see in Epic, unfortunately, even though the user interface design has improved, it's still not a complete set of data, because we haven't really sort of connected up all the different electronic health records across the country.
I see Naomi is asking a question about what kind of health outcomes might we hypothesize it could change with better access. I think, one that's probably not at all too much of a stretch is, decreased repetitive ordering of things like imaging. That's good not only from a healthcare cost perspective, but also from, you can imagine, like radiation exposure perspective, when you're ordering another CT scan when somebody maybe had one a week ago at an outside facility. I think that there could also be important outcomes that one might find in terms of speed to diagnosis that could also impact things such as length of hospital stay. Because if I have all the tests that I need while I'm admitting a patient, because they've already been done in outside settings, that decreases the time for me to collect that information otherwise.
Yeah, the other outcomes that we've seen have been sensitive to better information sharing is the likelihood of being admitted to the hospital from the ED. So if ED staff have better access to your records, there is sort of less likelihood that you'll be admitted to the hospital. The other outcomes, there are other outcomes that have been looked at, but I'd say the evidence is more variable in terms of the impact. But I think this repeat lab and imaging utilization and likelihood of being admitted to the hospital are probably the two where there's a pretty strong set of evidence that they're improved by having better access to prior records. I also believe the diagnostic one is true. It's hard to measure because accuracy and time to diagnosis are hard to measure. Let's see. So there's a question about approaches used to measure teams. So we actually just finished a really interesting study that's currently under review. So we don't have the paper to share quite yet, but where we looked at team experience in the ED and whether it predicted time to TPA for patients for acute stroke. And we measured team experience as basically how often had the people who were actually treating an index patient previously worked together in the past 6 months, again, as measured by audit log data, like how often had they both touched the record of previous patients. We basically created like a network type measure based on those like dyadic weights. And we did this at UCSF and Stanford and Kaiser Northern California, all their 22 hospitals, which I think was pretty cool to be able to do this work at that level of scale. And we found that both overall team experience and prior experience specifically on TPA administration cases were both associated with shorter time to TPA. So that's a very sort of concrete example of how we measured sort of a team-based measure and then like associated it with a patient outcome, time to TPA, which is already like a pretty well-managed and important outcome So the fact that we could even find variation in performance to kind of associate was, I think, really exciting. But I hope that that's just the tip of the iceberg in terms of those types of studies. But as you get to clinical outcomes, you do really have to think about like what outcome and then what dimension of teamwork or individual work is sensitive to that. So you do sort of move from, AJ type studies where you're looking at these really, large scale behaviors across large scale groups to needing to get down to like pretty fine grained patient cohorts and very specific types of team or individual behaviors. Anyway, they're both important. They're just sort of represent two types of research, that answer, sort of different types of questions. Ben, do you want to answer this question about like how you look at the volume of information being reviewed? That's probably come up most in like the trainee growth chart study of like, how do you think about this fire hose issue and, how much is being reviewed and is it the right set of information?
Yeah, I mean, it's tricky. And I think the question was asked in the context of primary care, and the growth chart project is in the inpatient setting. It's not primary care, but I used to do ambulatory care a long time ago. And so I really empathize with the fire hose comment. So I think it's a little bit a matter of, look, there is tons of volumes of information. You could spend all day reviewing information. What's the right information at the right time? The way we sort of tackled that with the growth chart is really with these focus groups, where we did modified Delphi approach with focus groups of attending physicians that spanned a range of experience, and kind of asked them, what do you consider essential to be reviewed at different stages of training? And anything beyond that is terrific if a person has bandwidth or time to review it, but this is sort of like the minimum essential. What's really tricky about that is that the minimum essential, frankly, will change depending on what the patient presents with. And so at least for the growth chart, I mean, we're in version, what I'd call 0.1, which is to say generically, irrespective of what the patient may present with, what is the minimum essential things that should be examined. And not surprisingly, I mean, vital signs and labs were quite near the top. But there was quite a bit of variation in other things, like reading radiology reports was ranked, fairly high among most of the clinician educators. But actually, to my surprise, looking at the radiology image itself, what had a wide amount of variability in terms of what they felt, whether they felt that was important or not. I think we're, ultimately in the early days of trying to understand volume and what is sort of the essential elements so that people aren't really buried by the volume that is available in the EHR.
All right, we probably have time for another question or two, or comments or reflections are also welcome.
Yeah, I mean, I totally agree with Leah's comments. In fact, when I used to do primary care, I felt like there should be time in the day that's allocated to responding to patient messages, spending time between encounters, or maybe aggregated during the day to do some chart review, as opposed to back patient encounters, because it doesn't really honor the need to review information and reward the physician for spending time doing those sorts of things. So Leah, I agree with you. Need more time. That feels maybe like a healthcare business or operations decision, but I do think that there are some important policy implications related to that.
Yeah. So maybe just to address, I think this question is really about how do we kind of reflect the fact that in primary care, like the EHR related work can be much more substantial. Information review, we see it in the in-basket side, responding to the volume of patient messages. Primary care is doing more. So AJ's leading a set of work around the inbox piece of things, like how do we kind of think about different models for inbox that could help address that. We also have a current project that the American Medical Association is funding, where they have asked us to use a large national data set similar to the one AJ described, but from Cerner, which is another large EHR vendor, basically to calculate if you were going to say a 40-hour work week, what would be the amount of patient scheduled time given the amount of EHR time that's required in that for that specialty to get to a 40-hour work week. And so I think having previewed those results already, what you're going to see is that the number of patient scheduled hours in primary care are going to be much lower than other specialties, given the fact that, when combined with their EHR time, that gets them to a 40-hour work week. So I think these differences have been recognized in the literature, and from a sort of research perspective, we're trying to kind of advocate for that. We need more time by doing a better job of sort of precisely quantifying, well, how much time is taken up by these different EHR activities by specialty. And so then how might you need to adjust schedules and payment and everything else to kind of reflect that extra amount of EHR based work. All right, Joanne, any closing thoughts or comments?
Yeah, well, thank you so much. I've actually already emailed AJ about an idea with that team and burnout area, because I think there are a lot of opportunities. And I imagine that some of our colleagues who are on this meeting have also emailed all of you with different ideas, and the questions were really lively. Thank you so much for being here and doing this. It was wonderful. And I want to make sure everybody is aware that next month, April 20th, I believe it's April 20th is the Wednesday. Our next health policy grand rounds will be Maya Rawson-Slater, who is at Stanford University, and she will be doing a presentation on paid family leave. So we're really excited about that. Keep an eye on our website to get the link for the grand rounds for health policy grand rounds next month. And thank you, Ben, AJ, and Julia for doing it for us this month.